안녕하십니까, 김경원입니다.
Greetings, this is Dr. Kim Kyung-won. It's great to meet you again today with another surgery video. Today's case involves a 64-year-old male patient who came in with missing teeth in the upper right posterior region as seen in the panorama. The tooth at the most distal area is presumed to be a wisdom tooth. About 3 months ago, the patient had teeth extracted in the upper posterior region at a private dental clinic due to significant mobility. From the panorama, it seems there was a bridge using teeth numbers 4 and 7. There are missing parts, and the patient's past medical history includes BPH, for which he is taking medication with no other significant issues. As for now, keeping number 18 seems pointless and not beneficial for future occlusion, so the plan was to extract it and place implants in positions 14, 16, and 17 in a bridge form. The plan was to use OneCAS kit and do crestal approach for sinus lift. CT scans shows a significant buccal wall defect in position number 14. GBR using Collagen was deemed necessary here. Yes, Osstem could be used, but in this case, this is contained a defect where there's bone in the anterior and posterior area. Therefore, Collagen would suffice. In the case of number 16, the implant was placed slightly more distally, and this is number 16 and 17. Position number 17 is near the crown area of the existing tooth number 8. After consulting with one guided team, the plan was to place implants at positions number 14, 16, and 17. KS3 was chosen. As we all know, the appearance is similar to TS3, which makes the surgical procedure familiar to most. However, due to its narrower connection, the KS3 implant provides a thicker implant wall, offering a more secure option for those who have experienced implant tears. In number 14, KS3 BA surface 4.5 by 10 mm implant was planned, and GBR was anticipated due to buccal bone defect. In number 16, KS3 BA 5.0 by 10 mm implant was planned on CT after evaluating the situation. The minimum available residual bone height was approximately 3.6 millimeters, and the maximum bone height was approximately 5.7 millimeters. So it's slightly under 6 millimeters. As for number 17, the alveolar bone height was about 6 millimeters because we positioned it more distally. OneCAS was to be used to place 2 implants in this way. If you take a look at number 16 as mentioned earlier, the residual alveolar bone height was assumed to be 3 millimeters. It's slightly over 3 millimeters. OneCAS was used. The initial drilling started with 2 millimeters. I'm sure you have a lot of experience using CAS, but if you use CAS for free end cases, it's quite difficult to drill 2 millimeters when the residual alveolar bone height is 3 millimeters. However, if you use OneCAS kit, then using guide, you'll be able to drill 2 millimeters much more easily. From 2 millimeters, OneCAS drill was used up to 3.8 millimeters. It was gradually increased, and after penetrating the sinus floor, hydrolift and implant placement was to be done in number 17. The residual alveolar bone height was 6 millimeters, and 5 millimeter drilling was planned for initial drill. This is immediate post-op situation in number 16 and 17. You can see that within sinus cavity, bone graft was performed sufficiently. Cone beam CT was taken In number 14, as mentioned, after implant placement, AOS collagen was used for GBR and the buccal bone defect. In number 16, as shown, AOS has been grafted into the sinus sufficiently. In number 17, in the same way, bone graft was performed and implant was placed. This is a 2 weeks post-op image, panoramic image, and after 1.5 months. This is after 4.5 months. CTs were taken. In number 14, you can see that GBR is becoming mature, and next is number 16 and 17. Because there were no major issues, provisionals were delivered. This is after 7 months, and this is with final prosthesis. At initial visit, teeth were missing in these areas, and implants were placed nicely in number 7. In number 14, after 7 months, you can see that buccal bone is nicely being maintained. In number 16 and 17, there's a slight mucosal thickening in sinus cavity, but there's no major issues, and it's nicely being maintained. Let's take a look at the surgical clip. First, number 8 was extracted. There's nothing special. Surgical curette was used to sever the periodontal ligament, and forceps was used for extraction. In number 17, where we wanted to place the implant, it was close to number 8. One guide template was positioned. One guide template was adapted very nicely. Tissue punch was performed. In number 14 area, regular size tissue punch was used, and overriding mucosa was removed. Number 16 and 17, wide type tissue punch was used. Overriding mucosa was removed in this way. So number 17, it's going to be slightly mesial to the extraction socket. Template was removed. I checked whether overriding mucosa was thoroughly removed before proceeding with the surgery. One guide template was positioned once again. In number 14 first, flattening drill was used full length. Because there was buccal bone defect, no major issues erupted. This was followed by initial drilling. In number 14, .5 by 10 millimeter one guide drill was used. Preparation was done in this way because initial drilling was used. Using double contact concept, drilling was done properly. 4.5 by 10 millimeter final drill was used. KS3BA surface 4.5 by 10 millimeter implant. Implant was positioned, and using engine, it was placed about 80%. Implant driver or torque wrench was used to get final position. Yellow marking was used to adjust hex positioning and depth control. You can see that yellow marking is where it should be. Initial torque is about 30 Newton centimeters, and flattening drill is used in number 16. Flattening drill was done because the plan was to place it deeply. Flattening drill was done, and because the residual alveolar bone height was assumed to be 3 millimeters, 2.2 by 7 millimeter twisted drill with 5 millimeter stopper was used first. With the use of OneCAS kit, 2 millimeter drilling can be done. 2.8 by 7 millimeter drill with 5 millimeter stopper was used. Diameter 3.8 drill with 5 millimeter stopper was used. Drilling was done up to the final diameter. We're going to proceed gradually. 3.8 by 7 millimeter drill with 4 millimeter stopper was used. Drilling was done up to 3 millimeters. In order to check whether penetration occurred, the depth gauge with 7 millimeter stopper was used. So you can see that there's no contact here. After that, a 3.8 by 7 millimeter drill with a 3 millimeter stopper was used to drill up to 4 millimeters. 6 millimeter stopper was added to depth gauge, and you can see that the sinus floor was not penetrated, so there's no contact. After that, 2 millimeter stopper was used, so drilling was done up to 5 millimeters. So I felt a sense of penetration here, and a 5 millimeter stopper was added, and using depth gauge, you can see that stopper is in contact with the template. So the sinus floor was penetrated here. Hydrolift was performed thereafter. In 3 cc syringe, using 0.5, gradually aspiration was performed. There's no air and there's negative pressure, so you can assume that sinus membrane was lifted without damage. Negative pressure was formed and sinus membrane was lifted. AOS bone graft material was used with bone carrier. Bone grafting was performed in this way. If you do it gradually, you will not face any problem when performing similar technique. Aspiration was done to check negative pressure. There's a negative pressure and there's no damage to the membrane. KS3 5.0 by 10 millimeter implant. The implant was placed 80% using engine. More so than thought, bone quality was in favorable conditions, so torque wrench was used to adjust the final depths. Primary stability seems sufficient. Over 30 newtons of primary stability was achieved. You can see the triangular portion of implant driver. So in number 17, flattening drill was used, and we assumed 6 millimeters here. 2.2 twisted drill with 2 millimeter stopper was used to drill up to 5 millimeters. The drill hole size is expanded using 2.8 by 7 millimeter drill with 2 millimeter stopper. OneCAS drill was used to drill up to 5 millimeters. 3.8 by 7 millimeter drill with 2 millimeter stopper. So drill hole size was expanded using this. Final drilling. Drilling was done up to 6 millimeters using 1 millimeter stopper. In order to check whether the sinus floor has been penetrated, 4 millimeter stopper was used on depth gauge. Depth gauge is not fully going in, so sinus floor was not fully penetrated. 7 millimeter drilling was done without stopper. Drilling was done up to 7 millimeters. 3 millimeters stopper was used on depth gauge. You can see that it's going in sufficiently and there's contact. So sufficient sinus floor penetration was done and hydraulic lift ensued. In 3 cc syringe, you can see that upon aspiration, there's a blood regurgitation and negative pressure, so you can indirectly check whether there's any sinus membrane damage. Because there's negative pressure, you can confirm that there's a sinus membrane elevation. AOS graft material was used with bone carrier. Bone condenser was used. Bone graft was done using crystal approach. You can check negative pressure once again and confirm there's no sinus membrane damage. By doing this, the graft material will be concentrated. 5.0 by 8.5 BA surface KS implant was used. The implant was placed about 80% using engine. Hand wrench was used to adjust depths. Hex positioning can be done using the yellow marking as well as the triangle. The primary stability is slightly under 30 Newton centimeters. You could see that the implant was positioned correct. One guide template was removed. The smart peg was used to measure ISQ values. 14 first. In number 14, it's 66 and 65. In number 16, it's 73 and 72. Number 17 is 59 and 60. Healing abutments were connected. Primary stability was best in number 16, contrary to the original assumption. Healing abutment was connected to number 17. In number 14 for GBR, incision was made. Minor crystal incision was made to expose buccal bone defect. You do not need to reflect flap significantly. You could see that there's implant exposure towards the buccal side. Healing abutment was connected. In the buccal bone defect area, AOS collagen was used. Rather than using particulated bone graft material, if you use collagen material, it's easier to apply, and even without the use of membrane, healing can be done nicely. If you use AOS collagen, you can do socket preservation or GBR in the case of buccal bone defect easily. AOS collagen was used to do bone graft in the buccal side because minor flap reflection was done. Membrane was not used. From the mesial side, suture was done. Towards the palatal side, so I used the canine tooth to do anchor suture. If the suture goes around the canine as shown, it presses upon the flap itself. Also, there's less tearing and adaptation can be done nicely. Mesial tooth was used as anchor for suture. On the distal side, interrupted suture was done. In the area where there used to be buccal bone defect, you could see that there's more volume because of GBR. Figure of 8 suture was used. In the area where there was tooth extraction in number 8, figure of 8 suture was done. Today, the case involved a simple GBR using EOS collagen in the buccal bone defect area in number 14, along with a Crestle approach and implant placement in number 16 and 17 using OneCAS kit. Thank you for watching.